Welcome back. This is the third and final video in our lecture for today. And what I'd like to do is to tell you about a second case study, which is around HPV vaccination in the Somali community, and just wrap up with some concluding thoughts. So we know that HPV is a very common infection that can lead to cervical cancer. And the HPV vaccine these days, in its latest version, can prevent around 90% of cervical cancers. So really for the first time, we have the potential to potentially wipe out a whole cancer through vaccination. The vaccine is suggested from 9 years of age, and that's been recently, there's been some changes with the FDA that looks like it will be able to be available for men and women up to 45 years of age. And as I mentioned before, women from East Africa have some of the highest rates of cervical cancer in the world. So this is a particularly important tool in relation to thinking about cervical cancer prevention. We also know that Somali patients have low rates of HPV vaccination. The HPV vaccination tends to have kind of lower rates across the board, hovering more around the 45% and slightly above for the general population. So 10% is very low, but it's a vaccine that there's issues with in general. There's some common barriers towards receiving the HPV vaccine, and one of those is, as we talked about in the last case study, is there tends to be a fairly limited knowledge about cancer and cancer prevention for all kinds of reasons, and this comes into play in thinking about HPV. There is also fairly low knowledge about HPV itself, and one of the things that we have also learned is that there can be confusion between the terms HPV and HIV, which obviously can be a compounding factor. If a provider is sitting talking with a patient and offering them the HPV vaccination, and what that patient is believing they're talking about as HIV, they're having very different conversations than they think they're having with each other. There might be a range of cultural or religious beliefs around the HPV vaccination that can make it a little bit more challenging in thinking about the vaccination. There can be health literacy challenges, and we know that there can be some distrust in healthcare providers around vaccines in general. Not many people realise this, but Somali immigrants tended to be one of the most highly vaccinated groups until recent years, and extensive targeting by anti-vaxxer advocates that have been targeted to the Somali community have really turned that around, and we see some concerns or distrust around vaccines leading to things like some of the measles outbreaks that we've had in Minnesota in the Somali community. And again, this is all somewhat exacerbated by the limited experience or prior exposure with preventive health care. And there tends to be a lack of culturally tailored health promotion or clinical practice information that targets some of these specific barriers for Somali patients when it comes to thinking about HPV. So what we decided to do was, and this is an example of a different type of qualitative approach called video reflexive ethnography. And video reflexive ethnography is much more of a visual and ethnographic method than the example from case study 1, which was all mostly generated off focus group type data. So VRE is a participatory and change-oriented approach that really has a focus of taking a close look at a healthcare practice from within. So often when we think about innovations in healthcare, we might think that people might be coming in from outside the system and offering solutions or new ideas for the system to try. VRE posits that we can actually find a lot of innovation from within if we have some methods or tools that can allow us to explore the expertise of those within systems and engaging them as change agents. It has 3 main components, and the first is the use of video. And what the video piece is about is recording in situ real-world interactions that may be happening in the clinical setting. So there's real-time data of interactions happening. In this instance, the example would be between medical assistants and patients being offered an HPV vaccination. Often in this type of work, we can ask a person and we can ask a provider to recall for us what might have happened in a particular clinical interaction. And our memories can be somewhat unreliable witnesses. But if people can actually watch themselves in the interactions, it gives us an ability to change the conversation, to be able to have people review their own practice from their perspective. Can be very helpful. Reflexive analysis is the second main component of VRE, and it's a participatory approach. So reflexive analysis is engaging with those in the videos or closely impacted by the videos as expert participants and viewing their own practice from a new perspective. So step one, for example, is for us in this instance to record videos of medical assistants offering the HPV vaccine to patients in primary care. Reflexive analysis allows us to actually engage those medical assistants to say, how about let's all sit down together and view these videos, and you can observe your own practice and the practice of your peers, and together, using your own expertise, provide an analysis of what is happening in these videos. The third aspect of video reflexive ethnography is the ethnographic approach itself, which signals the real-world context that we're capturing by collecting video in the setting. And it also speaks to the fact that there's lots of other data happening in and around these videos. So while we might be in the field collecting videos segments, there's all sorts of other interactions happening around that we are observing and able to also collect as data to be able to share with the people that we're working with and to be able to analyze. Now, a process like VRE is obviously can be quite challenging from the point of view of providers. So someone's going to turn up and ask to recruit patients and record the experiences that somebody may be having and offering particular types of clinical care, and that can be a big ask. We were able to partner with one clinic locally who were feeling very exasperated by having a 10% HPV vaccination rate among their Somali patients. We had done some prior focus group work with Somali young people between 18 to 25, and we had collected some of their impressions about what some of the barriers were and what some of the issues they were having or thinking about in relation to deciding to undertake an HPV vaccination or not. And we were able to partner with this clinic and with these medical assistants. And the idea of VRE is to build a collaborative partnership. So we're not going in and imposing ourselves. We're sitting down and forming a partnership where we get to say to them, we know you're doing your absolute best, and we know that you wish this was higher. Let's do this work together to see if we can find opportunities for growth. So it's very important in negotiating the work that it's not punitive, it's not looking for failings, it's not looking for where people have done anything wrong, but it's taking the opportunity to work together as partners to find good practice and to find good opportunities for practice. And so there's a very important piece of partnership building before VRE can successfully proceed. So our research questions in this particular pilot, firstly, was to examine the acceptability and feasibility of using VRE in a primary care setting and with Somali patients along with their providers. And secondly, to identify opportunities to enhance communication to address common and culturally informed barriers in relation to HPV vaccinations between medical assistants and Somali patients. And in this instance, we chose medical assistants because often they're the very first conversation a patient might be having about HPV vaccination when they come along for a clinic appointment. So, in terms of methods, one member of our team conducted 3 weeks of field work, and that meant spending some time in the clinic, getting to know the medical assistants, just doing some observing, and as people felt more comfortable, also starting to do filming of appointments. Daily appointment lists were reviewed, and we were able to target appointments that were identified as being likely to have a discussion arise about HPV vaccination, which is pre-work that's often done ahead of a clinical appointment. The medical assistant will review who might be eligible for which types of preventive healthcare checks or screening or vaccines. So that was just fitting in alongside what they might ordinarily do. The research intern or with some support from a bilingual Somali community health worker who was embedded at the clinic, approached patients to ask if they'd be willing to have their exchange about HPV video recorded. And we actually recorded anyone over the 3-week period, Somali or non-Somali, so all comers were asked. And this allowed us to explore some contrasts between the experience of Somali and non-Somali patients. Over the 3 weeks, we recorded 8 video clips and collected a lot of other data around what was happening in the context as well. And interestingly, even though it was just 8 clips, we had a huge amount of variation in terms of different types of patients in that small sample. We held 3 participatory data analysis sessions with the medical assistants. And those analysis sessions basically had the format of us and the research team selecting clips or portions of clips that showed a variety of practices. And if that medical assistant agreed, so no one had to feel put on the spot, but if they agreed that we would share that video clip with the whole group. And the video clips viewed include Somali patients, non-Somali patients, interpreted visits, non-interpreted visits, a range of different contrasts. And the discussion was guided by key questions from the research team that focused on looking for these best practices and opportunities for improving communication. Some of our findings were that there was an awful lot of standard work, which is one of the real goals in the health system, to offer standard, consistent ways of offering healthcare delivery. However, it became quite clear in watching the videos that while the work might be standard, the patients aren't necessarily standard. And so patients might be coming in with wildly different starting points in terms of their knowledge about HPV. But the conversation was almost identical every time, which was very interesting for the MAs to see because they'd never seen each other do these conversations. So they were very interested to see how they all handled, raising these conversations. And there's just a couple of quotes there from our team discussion there around some of the differences. For the team itself, there was quite a lot of conversation in terms of understanding why there were differences between the Somali and non-Somali patients. Some felt that it might be because of people being at different points in the series, and that if a non-Somali patient had already commenced the HPV series, they were often really quite enthusiastic about completing it. But there was a lot of difficulty getting people to start. It also became clear that the medical assistants weren't always completely sure what they should be saying or doing about HPV, and that they wanted to say the right thing, but they wanted to make sure that they were saying the right thing. And it identified for us that there were some dilemmas that they were facing in terms of how much information they should be sharing about HPV. One of the things that can be a real challenge is there's some sensitivity in talking about sexual activity. That's a common barrier across all groups in relation to the HPV vaccination, but it might be a little bit more of a barrier in Muslim communities to talk about things that might imply premarital sex could happen. And so actually this process itself allowed some of the MAs to be able to clarify with each other some of the ways in which they wanted to be having these conversations. We also found that Somali patients were mostly always saying no to having the HPV vaccination, but in a way that the MA might not always recognise. As someone who's neither Somali or Minnesotan, I think there's some really interesting ways in which people have cultural behaviours around saying no. And I've had to learn over years that there's certain ways Minnesotans say no, there's certain ways Somali folks might say no, and maybe if you can't recognise that in each other, it can lead to a lot of ambiguity about what's happened in the encounter. So one other thing that became clear by watching the videos is that while some people were looking like they were just delaying talking about HPV from the MA's perspective, this patient may have just been saying no. And that changes the nature of the conversation. If you think somebody is just hard declining it, you might actually alert the provider to have a different type of conversation, as opposed to feeling somebody is delaying it. So there's some real cross-cultural barriers in terms of speaking past each other in some of the interactions. There was also it was also clear that there was some uncertainty about the role of interpreters and what interpreters were saying. So we also engaged our bilingual community health worker in the analysis process, and we were able to demystify a little bit some of how interpreters were talking with patients and explaining what the MA had said. And that was very useful as well, and that sometimes the MAs were feeling a little bit unsure whether the interpreters were saying exactly what they had been asked to say, and our community health worker was able to also listen and interpret and clarify that more often than not they absolutely were saying what was asked of them. There's also, we had some findings around developing sustainable ways to provide tailored information is absolutely needed. So, for example, the MAs could see that there was a need to provide tailored information, and together they were able to review and look at some of the things that they have done in the past, such as trying to improve colonoscopy rates. And they were able to say, well, what did we do to improve rates with this initiative or that initiative, and how can we draw on the things that we've learned worked well for us clinically in relation to one condition, and how can we make sure that we use that well for another. In this particular instance, they were able to reflect on the fact that they had an initiative around improving colonoscopy uptake, and so they had specific sheets of information available in the clinic rooms, and felt that if they had one that was related to HPV, that would be very helpful. Some people identified that that information was available, but it wasn't information that everybody was accessing or finding very helpful. And, you know, we also identified a need to have specific language-based information, and that one of the things they had worked out was a problem with some of the information sheets they'd used in the past was that it really needed to also be available in Somali for Somali patients to have the best chance of being able to read them. So we found that while there was a need to provide tailored information, there were a few steps that needed to be in place to make sure that it worked in relation to the type of information, the location of the information, and the language used. We were also able to bring into our discussions case studies, examples that had been observed through our ethnographic data collection, even if we hadn't collected them on video. And in this case example, I'll share with you, a Somali patient had been offered the HPV vaccination and said no. And that's the interaction that we had on video. After our video recorder was turned off, the patient had brought her 6th grade sister along with the visit, and it had turned out being captain of the winning debate team at school arguing the case for HPV vaccination. And so little sister was also in the room, and she actually convinced her older sister that by giving her all of the information she'd used in the debate team, that having an HPV vaccination was a good thing. And the patient actually changed her mind, agreed, and took the first of the series of the vaccine that very day. And it led us as a group to think about how can we find ways to bring the little sister effect into the room with us, where we've got key convincing information that's culturally specific, that can change the discourse around HPV vaccination. When we dug a little bit deeper about what is the information right now that clinics have to be able to share about HPV vaccination, this was the flyer that the CDC provide, which has a lot of good information on it, but it's a little bit generic and it doesn't necessarily fit some of the concerns that the Somali patients might have had. And so we were able to draw on the focus groups we had done with young people, the little sister effect, the knowledge from the providers themselves and the MAs, and suggest a new tailored information sheet. And this is it here. Again, it's riffing off the CDC a little bit, and that we've got 6 reasons to get the HPV vaccine, just as the CDC do. And number 1 is to not only emphasize that it's really common, but that it's not the same as HIV, because we've come to learn this through our work together, that there can be confusion. Number 2, preventing cancer is better than treating cancer, and there's a quote from the Quran there, and that was possible because we were able to borrow from some of our work around faith-based messaging from case study 1 and integrate it into here. Message number 3 spoke to it being safe and effective to have the vaccine. And then with message number 4, we were able to talk directly to the fact that women from East African countries should be particularly concerned. They have an elevated risk, and that is something that the MAs didn't know, providers frequently don't know, but adds to the seriousness and importance of doing this work, and that we felt patients might be willing to know this. So we developed this information and actually were fortunate enough to be able to, make it look nice. I have a strong preference for, through my experience in doing work in the community, to developing information that's bilingual and that it has the Somali and the English kind of simultaneously side by side. And that's particularly important in this instance where we might have an adolescent who might feel more comfortable reading the English text, and we might have parents who might feel more comfortable reading the text in Somali. So this allows for both to take place. So what did we find? We found that the video reflexive ethnography tool was very novel and feasible, and that it really helped to engage the MAs and participants in seeing their practice from a new perspective. We did find that patients and MAs were both willing to participate and be filmed. And in saying that, everyone who agreed to be filmed was over 18, and so we probably have to do more specific work in targeting teens. That might take more effort. We also found that vaccine work practices were able to be reviewed and potential cultural tailoring identified, and that we could find opportunities for improving communication by collaborating with those MAs and reviewing some of their practices and doing some thinking together about how to change some of the things that they were experiencing. I think one of the things that came through pretty clearly was if you have a 10% vaccination rate, that means 9 out of 10 times you're hearing no from a patient. And the MAs were able to give some voice to having a little bit of fatigue around declined vaccinations, and it was useful to be able to talk about the impact of that on their practice. We found through our efforts that we started at this clinic with a 10% vaccination rate, and after 6 months, we had shifted that rate to 35%. So all of this work, when put into practice, actually turned out to have a very significant impact on the vaccination rate itself, which was great news. And that's just at the 6-month point. So we'll keep reviewing that data and seeing what the long-term and sustained impact has been of being able to implement this modified messaging. So just in way of a few final reflections, a few top tips around qualitative work, as you might be interested in doing it or developing it, is to find a really good mentor for the work, because so much of this work we learn through doing. So finding someone who can work with you and guide you as you're thinking about those 4 aspects of what kind of data, theory, reflexivity and context influences any projects you might be wanting to do. Qualitative work essentially has a has at its core the idea of finding out the breadth and depth of experiences. We're not necessarily trying to find conclusions. We might be finding really broadening what we know. And that means we might also show contradictions in experience. It's not necessarily about finding a consensus. We can build the integrity of stories through thinking about a variety of participant experiences and incorporating quotes from and information about participants in a broad range. And it's important to think carefully about respecting anonymity. So, for example, it's very hard for me to show you videos from the VRE project because we want to do absolutely the best we can to respect anonymity, which can be a little bit more challenging when we're sharing people's stories. And so we have to have real good sensitivity around that. And qualitative work generally avoids truth claims, so we don't tend to spend much time saying this is the answer, but rather some people have this experience, others might have a different one. So it's a different type of work than trying to find a conclusive answer. And in terms of just some final reflections, there's really a very wide range of ways to apply qualitative work to broad range of settings, and there's no one size that fits all or any one right way. But the ability to broaden our view and raise new questions is an absolutely vital contribution to furthering knowledge and research in general. And qualitative research is just growing a stronger and stronger foothold, even in quite traditional clinical research, because it's essential for us to include the perspectives of people we work with and to understand more about the processes at play. And qualitative research can do that. And to spend some time reviewing the use of those four aspects of data theory, context, and reflexivity can be very helpful for guiding quality through your qualitative work process. So I hope that this has been helpful. I know it's a little bit awkward to be delivering this in a format where you can't provide questions, but I'm more than happy to answer follow-up questions. And please work with your tutors to just get those shared with me, and perhaps we can find a way to share that with each other. And thank you very much for your time.